Welcome to this session on the symposium with live case on TAVI. This is a session on redefining precision and performance of TAVI, advancing clinical outcomes with the Evolut FX Plus system, sponsored by Medtronic. I'm your anchor person today. I'm Michael Lee from Hong Kong, and the spokesperson for this session is Dr. Kim Hui Chu from Malaysia, and we have procedural analyst Dr. Anurag from Thailand, and our expert discussant Dr. Wu Wu from Vietnam. So please join us actively by asking more questions. You can post your questions on the app, or you can actually use the microphone here to ask questions, give comments anytime during the case. So without further ado, I should just very brief word on the session objectives. So in this session, we would actually highlight the use of the Evolut FX Plus platform, and especially for the treatment of small annulus as well as concomitant coronary artery disease. So the operators over the National University Hospital will show you a step-by-step deployment of the Evolut FX Plus system and highlight the differences with the Evolut R platform. I think most of you in this part of the world are still using the Evolut R, so we'll show you how FX Plus is different from the Evolut R. So this is the team, as I mentioned. We will have two poll questions, one right here, and then during our final discussion, we will actually do the second poll question. If you can see the question, is up there. So which clinical outcome concerns you most when performing TAVI? Is it hemodynamic and durability, or commissural alignment and coronary access, or permanent pacemaker implantation rate at the end of the procedure? So I don't know how many of you voted, actually. So I think I would say majority will be more concerned about the hemodynamic and the durability. Okay, some would prefer pacemaker. I think all of these factors are important as we move on to lower risk, younger patients, and we will address these issues throughout our case. And then I think we would actually start with one video presentation by Dr. Gilbert Tang first. He could not be with us today, but he's actually made a recorded video, which we will show you, is on a lecture on the redefining precision and performance in TAVI, the clinical outcomes with the Evolut FX Plus system. Can we have the video from Gilbert?
Hello, today my presentation is on redefining precision and performance in TAVI, advancing clinical outcomes with Evolut FX Plus. Here are my disclosures. The FX Plus system is a novel valve design, you can see, with 4 times larger windows to enable future coronary access. This is mounted on the Evolut FX delivery catheter system, which has been shown to have improved flexibility and control for precise, predictable deployment. You can see that for the Evolut FX Plus, each window is the size of 4 normal frame cells positioned 120 degrees apart between the transcatheter valve commissures. And this enables coronary access through the implant. You can see here, the green color shows the large Evolut FX Plus cell right straddled between the 2 commissures. And you can see that here with a coronary guide catheter position angle, you can engage the coronary easily. Look at the cells here. The 23 FX Plus has the window of 27 French, and then the 26 and 29 have around 21 French, and the Evolut 34 has 23 French. And you can see the ceiling skirt is still around 13 to 14 millimeters, and then the height from the cell to the inflow, it's around 28 to 30 millimeters. Now look at, based on CT analysis, some of the coronary anatomies where the coronary arteries orifices are located. You can see that typically the right coronary in green is higher than left coronary in blue, but they're all within range of the big large windows. So coronary access, especially you achieve optimal implant, should be relatively straightforward. Now, how do you see it in actual procedure? You can see that here, the windows, ideally, you would go into a cusp overlap view if it's a perfect alignment, and you can see that this is a large window here overlapping each other. But in the free cusp view, you can also see what I call a single X sign, because you only have one layer of a frame that overlays over the large window, and you can also try to pay attention to that. And that determines where your windows are relative to the commissures. Now, we know that in terms of optimizing the commissure alignment for the Evolut platform, you would put the flush port at 3 o'clock, and then in the descending aorta, typically the head marker on the outer curve, and then when you track along the arch of the ascending aorta, that relationship is maintained. And so if you can do that, you have 96.5% favorable commissure alignment. This includes perfect alignment or just mild misalignment. So how do you do 4 key steps in efficient Evolut FX Plus deployment? We typically start on the cusp overlap view with the FX Plus inflow at or just below the base of pigtail. Unwind the capsule to expose the inflow, no pacing is necessary. Now, once you approach the rapid 2-part deployment to 80%, is when you start the flowering of the inflow, pace at 150, you don't have to place too fast. This is just avoiding PVCs. And then pause the deployment, just as with flowers, inject to assess the depth. If the 2 or 3 dots add up below the annulus at the annular contact, you're good, especially even with the end flow as parallax. And so you rapidly deploy to 80% and then slow the pacing to 100, again, so that you avoid any pop-out. You swing the C-arm to the LAO where you line up the 3 dots to eliminate the parallax, and you assess the LCC depth. And sometimes if you need to, you can forward push if the NCC is high, and if both depths are okay, you release. So let me show you a case. 79-year-old female who's frail, multiple comorbidities, paradoxical low flow, low grade AS, certainly high surgical risk by a heart team. You can see here this annular and LVOT size fits very well for a 26 Evolut FX Plus. You can see the sinuses and the STJ are fine. Access is a bit challenging, but and also horizontal aorta at the root angle of 65 degrees. And so you can see some ascending aortic calcification as well. So certainly not a straightforward case. This was before we did the FX Plus, so this was Evolut FX case, but the deployment is exactly the same in terms of technique. We did want to pre-dilate in this situation because the leaflet calcification, and we deployed the valve in cusp overlap technique. So here you go. Here's you can see the ascending aortic calcification, the free cusp view, and the cusp overlap view. You can see that here we pre-dilate, and now you can see when we start deploying, you line up inflow to inflow, the head marker is facing you with the cusp overlap view. And then when you go to 80% on the LAO view, you can see that the left cusp is fine in terms of it's about 2 millimeters below, but the right, the non certainly looks very high here, and even at the cusp overlap view will be roughly at 0. So the concern is, should you recapture this to avoid pop-out? So at Sinai, we developed this code called a Sinai push technique. So if you push to the catheter to the outer curve, and you can see that the depth is gained here by 2 millimeters, then you'll be fine. You're not going to have a pop-out, and you can actually just release. So this is what we did. You release the valve. You can see excellent depth here on the cusp overlap view around 2 millimeters. Excellent commissure alignment. You can see that with the C-tab facing the right side of the screen, especially cusp overlap that you cannot see. And you can see on CT floral correlation, it's also well aligned. So no PVL, trace PVL next day, excellent hemodynamics, patient went home the next day. Now we have some new data this year from the 5-year Evolut low risk trial that was published in JACC. And you can see that here in the central figure, in 5 years, there was absolutely no statistical difference in terms of all-cause mortality or disabling stroke, cardiovascular mortality, or non-cardiovascular mortality between Evolut TAVR and surgery. So this shows that Evolut would be preferred over surgery. In the low-risk patient, you can see the hemodynamic performance is absolutely fantastic with sustained performance with both surgery and TAVR. But certainly, you can see that with TAVR, EOA, it maintains to be higher than surgery and also a lower gradient as well. Reintervention is very low. You can see that here, same as SAVR, valve thrombosis, and also very low. Paravalvular leak, mild, or 14.7% is certainly better than initially 30 in 1 year. So certainly, we know the Evolut platform, the paravalvular leak does reduce with time. So in summary, the Evolut FX Plus represents an advancement over FX and Pro Plus system in terms of larger windows for coronary access. Both FX Plus and FX implant techniques are identical. The 4-step efficient deployment technique optimizes implant depth and commissure alignment. And the Evolut low-risk 5-year data show no difference between TAVR and SAVR, sustained excellent hemodynamics of TAVR, and low rates of reintervention. Thank you very much for your attention.
Thank you, Gilbert. Unfortunately, you cannot be with us. Now, we will ask Jim Hui to show us the patient presentation of today's live case.
Thank you, Michael. So as a prelude to our live transmission, allow me to share with you the features of the patient on table today. So this is a lady who is 86 years old, presented with exertional dyspnea, and was then diagnosed to have severe aortic stenosis. As usual with degenerative aortic stenosis, you have the complement of cardiovascular risk factors of diabetes, hypertension, dyslipidemia, and she's got coronary artery disease, which is meant for medical therapy. Her BSA is 1.5, smallish kind of lady, but she's fairly independent, still able to be the main caregiver for her husband. Her complement of medications, and hemoglobin is 11, that's good. There's a raised NT-proBNP of 2,800, normal renal function. EKG shows sinus rhythm with a left ventricular hypertrophy and a strain pattern. No conduction abnormalities that we should be concerned about in this case. Angiography was done pre-TAVI and showed only mild luminal irregularities in both the left and right coronary arteries. The echocardiogram showed that she has got preserved LV systolic function. There's left ventricular hypertrophy on echocardiography. There may be a more prominent basal bulge of the septum. LV cavity seems to be smallish, and the aortic valve fulfills the criteria for severe aortic stenosis with a Vmax of 5.2, mean gradient of 65. Aortic valve area was estimated to be about 0.4. And the CASM score is more than 2,000, and of course, this is a degenerative aortic valve stenosis. So in summary, the assessment shows that this is an octogenarian with a mild frailty score. Given the features that we have described, however, her STS score is rather high, mainly probably driven by her age. And we found that the anatomy may be suitable, and we'll ask Anurag to discuss in a short while, and no major concern for coronary intervention at the moment, but in the future, definitely one of our concerns. I'll pass over to Anurag to discuss the CT analysis.
Yes, thank you very much. So we start with the measurement from the company. The company always says the annulus size, annulus diameter, and we choose the valve from that things. But usually when after we saw the report, we have to evaluate more. Like the membranous septum is not the standard, so the company didn't measurement for you. But it's important to say something to the patients that the patient have the high risk or the less risk for the heart block. The second thing is like we have to confirm that he have no alveolar obstruction, like the echo shows he have no sigmoid septum from this picture. So the other things beyond the measurement of from the company is the SOV. Like this case, if you choose the Evolut, it should be compatible with the 26 valve, and it should be have the SOV more than 27. But this data is not enough. You have to score compare with this cross-sectional view and the stretch view, because you have to predict the behavior of the calcium. Like this one, you can see it's a typical tricuspid degeneration because the majority of the calcium is on the tip of the leaflet. And if the calcium at the left chori is larger than this, it looks like this, and it have a big chance to have the chori obstruction when it's open up. This is all the things that you have to see by the CT scan, not only for the report from the company. Another things you have to evaluate, like the right chori is like this one. It's nearly possible because the height of the right chori is very high, and it have less chance to have this calcium to block the outflow. And other things, not only the SOV, the SCJ is also important, especially for the balloon expandable. If you have a short height of the SCJ like this case, it's just only 16. The valve compatible in this case for the 21 millimeter annulus, it should be 20, and it should be near, if the height is 15.5, it may be injury to the STJ, because it has the circumferential calcium at the STJ. So all the things here you have to concern and choose wisely when you have to choose the valve for the patient. Because in one day, even though this is the case example that we have the STJ injury, this case was 5 years later after do the balloon expandable valve, and it have the STJ dissection like this, and the patient have the sudden arrest.
Wow.
After 5 years. This is the picture that we can get, but at the end, she passed away because we cannot save her. So back to our case, you have the 21 annulus, and it should be matching with the 26, but with the 26 expansion, you can see that all the thing is fit in the small annulus, but we already quite sure that we have more space and the quality height is high enough. And like the distribution of this calcium, I think we are not necessary to do the cerebral protection because it's at the tip of the leaflet. We can separate it on the balloon pre-dilatation. Another thing you have to concern the access side. The calcium distribution in this case along the abdominal thoracic, and the Y is going in the outer curve. You can see that some part of the calcium here will be, the Y will touch this, and also the catheter will touch this. It's more easy to have the dissection here if you not very worried, if you not to beware of this during delivery, the catheter. And the last thing, with this picture, when you talk to your sales rep, you have to focus on the femoral head here because it's the puncture side. You can see the bifurcation compared with the femoral head. It's just in the mid of the femoral head or below. It can guide you during do the puncture at your cath lab. And also another thing in this case you have to concern is about the puncture site in the mid femoral head. You can see that it have the posterior wall calcium. It will be more more problem like the posterior wall capture with the big footplate for the closure device like MANTA. This is all the things that you have to see and planning from the CT scan.
Thank you, Anurag. That's a very detailed image analysis. So can I just start with you? So with your image analysis, which valve, you mentioned probably, but can you be more explicit which valve you go for, balloon expandable or self-expanding valve?
I think we can use both, but use with caution. And some cautions is mean difficulty. Like this case with the short STJ, yes, small SOV, and the calcium like that in the tip of the leaflet. Maybe I choose the self-expandable because of the hemodynamic and avoid to injury the STJ.
As also you mentioned about the small annulus.
Yes.
So if you go for balloon expandable, it's going to be 20.
Yeah, 12
adverse,
2 digits for the result of the hemodynamic.
Seldom use 20, 23 nowadays, just for the hemodynamics.
Yep.
Yeah, thank you. And Kim Hui, can I also involve you as well? Would you do pre-dilatation for this patient? And if so, what size of balloon would you go for?
Yeah, I like to do pre-dilatation for most of my cases. Custom score here about 2,000. I would like to pre-dilate. If you look at the minimal and maximal diameters, that's about 16 by 24. I think 16 is a bit kind of small. The mean I think we discussed was about 20 plus. So I will probably go with maybe a 18 or 20 mm pre-dilatation balloon.
All right. And lastly, Dr. Wu, we always talk about lifetime management, but this is an 86 years old lady. So how important do you think, when you consider all the poor risk factors that we mentioned, coronary access, hemodynamics, pacemaker implantation, how important is this for this elderly lady?
I think we have to put all the points to one patient. We think about the coronary access in the near future, durable of the valves, and also we have to concern about the pacemaker when we do the procedure. So all the things when we think about long life management. And in this patient, we also have to concern about the procedure complication management also. As Arun say that we have some risk of this patient. So in this patient, I agree that we should do the balloon first and 20 balloon is okay, and we
18 or
can
20, yeah.
yeah, and we can measure and we can take a picture during the procedure to see 23 or 26. Maybe I prefer both valve is okay, but I think the self-expandable valve is more preferable in this patient, in my opinion. Yeah.
We also mentioned, Kim Hui also talked about the coronary artery disease. Although it is sort of minor, moderate coronary artery disease, but 86 years old lady, future coronary access might also be important because she might run into risk of future coronary interventions. So coronary reaccess probably is another consideration for patients with coronary artery disease.
So in this case, not only the large cells for the FX Plus, but also conventional alignment would help with coronary access.
All right, let me go to the operator strategy and then we will go to the... Okay, Ivan Dicto from the National University Heart Hospital will be doing this case. And this is their plan. So right transfemoral access, they would actually pre-close with a POGAI, and then hopefully at the end, they will close with one POGAI and with additional angio seal. Patient will be under conscious sedation. They will pre-dilate with a balloon size of, we discussed 16, 18, or 20 balloon. I think we let the team decide. And then they are going to implant an Evolut FX Plus 26. Try to aim at commissure alignment, as we discussed, because of future coronary access. They will do it under slow pacing, 120 to 140. Because of the septal bulge and the small LVOT, so he mentioned that he also will be watch out for potential upward movement of the valve at the end of the procedure. So if we can go to the live case, to the cath lab, we would ask Ivan to start the case. Hello, Ivan, can you hear us?
Hi, Michael. How are you guys doing?
We are good. We can see you very well. Can you introduce your team?
Sure. Well, good afternoon, everyone, and welcome to our cath lab at NUACS Singapore. So my name is Ivan. With me, Dr. Chen Chi, cardiovascular surgeon. We have Shabna from anesthesia, who already put the patient on conscious sedation. William Kong will join us also to help us with the imaging after the procedure. And of course, we have all the team here, our nurse, our cath lab technician, also radiographer. It's crossed. So you can see just now we're struggling a little bit with the crossing, but we managed to cross with the JR4 and straight tip wire. So let's just exchange. So we've been doing some work while you guys discussing about the case. So I hear that you guys presenting the patient and the imaging. So what we've been doing is we already put the access on the right side. We deploy one per close. And then we also shows, take some picture. We can show you the coplanar view. So this is a very important view in which you can clearly see. I hope you can see clearly there, Michael. And then you can clearly see the three cuts there, which is very important when you deploy the TAVI. And this patient has a little bit of AR as well. So and then we go to the second angle, which is very important and very important for self-expandable Evolut, which is the cusp overlap, and which is usually in the REO caudal. You can see here the right and the left is overlap or near overlap. And in this view, where the picture is we isolate the non-coronary cusp, which is very important. This is we're going to try to implant the depth based on the non-coronary cusp location. So this is what we've been doing so far. We struggled a little bit with the crossing just now. We use JR4, we use AL1. We use Terumo wire. We even try to pace the patient a little bit, because sometimes when you're pacing, you stop the heart a little bit, the opening is a bit more, but we managed to cross with the JR4 and straight tip wire. I hope you guys can see the hemodynamic. This is a very tight valve. The peak-to-peak on the echo was 800 just now with the mean of 80. So what did the hemodynamics show here? The peak-to-peak is quite significant as well. Can you guys see from the main arena?
Yes, we can see the hemodynamics. Peak-to-peak
All right.
gradient is 90, maybe. Yeah.
Yes. So I guess we're gonna keep with our plan. We're gonna balloon this valve. And I think, we're debating between 16 to 18. If you look at the minor axis, this is about 16.5. So somewhere between 16, 18. But I feel like, we think that probably we have to open up a little bit. We will use 18 balloon here. A true balloon 18. What do you think, Michael?
Yeah, we should use a little bigger balloon here. They suggest either 18 or 20, but I think 18 is a reasonable choice to pre-dilate adequately before we put in the self-expanding valve.
Pigtail back. It's not a good position. It's just pigtail, right?
This is the safari wire.
Yeah, I don't like the position. I guess I think the tip of the wire. Can you go back AP, please? The tip of the wire, I think, is entangled in the mitral. Sometimes this thing can happen, and this is something that you need to pay attention to. So we will put a pigtail just to straighten up. And so I think the tip of this pigtail is in the left atrium.
Okay, yeah.
But again, we also aware that her left ventricle is actually very small, so we may not be able to push the safari all the way to the apex. Fluoro on. I'm holding the wire. So this is we put a pigtail just to reposition safari wire in the better position.
So for now, sometimes we actually insert the safari wire over the either a AR or JR catheter. Am I right? But some will still insist exchange to a pigtail so that you will get a better position, as shown in this case.
You guys happy with this? I think this is a much better position than just now, and I'm quite sure this is the LV apex right now. All right. So now, all right. Well, let's check the valve first. I guess this is an important step as well. Go back to AP. We check the valve before we balloon because there's always a risk that when we balloon the valve and the patient come unstable. Okay, two things to check here. Let me rotate, and usually clockwise rotation here. Put it in the lung pit. Yeah, a bit more. All right, right there. So first thing, the pedal, very good position. You off fluoro. Yeah, I think so. So the pedal is on the good position. And the other thing you look is at the line. And I think this is very important, especially for the bigger valve. You make sure that the line overlap is not beyond node 4. I think in this case, it's all, below node 4. You guys agree?
Yes.
I think this is a good valve, so I think we just leave it here.
I think it's okay.
It's just ballooned.
So it's going to be an 18 non-compliant balloon?
Yeah, so yes. So I'm using 18 true balloon here, Michael.
True balloon, okay.
So the BP is a bit soft. Can you support a little bit? Because we're going to do a rapid pacing shot. Can you get a flush with it? It's the wire, AP. Okay, I'm holding the wire.
So rapid pacing over the temporary pacing wire. We saw the temporary pacing wire.
Yes. Oh, I like this. Show more apex a little bit, if you can. All right, we ready? How's the blood pressure? All right, you adjust the thing. I mean, the key here is just to balloon a bit slow because most likely, okay. Pacing on, 180. Okay, balloon up, just hold the position. I'm inflating the slow. Okay, that's good. Balloon all the way up. 1, 2, 3, balloon down. Pacing off. Okay, I think that's good enough.
Yeah. It's expanded.
How's the blood pressure, guys? All right, so the blood pressure is a bit soft, I think, because of the rapid pacing. Fluoro repeat. Okay, good position. All right, so we're ready to deploy the valve. So I think, there's we like to take out the centron sheet. This is a 14 French centron sheet. We take out the sheet
Okay.
and then exchange with the inline.
Okay, inline sheet. Okay,
Yes, if be
careful.
careful. And
The wire,
push
yeah.
out without me. All right, well, the patient move a little bit. Always roll, guys. Always roll.
So you will try your best to do commercial alignment because of
Yes, we'll show you guys. Absolutely, we see. So I'm just going to do it a bit fast. So the camera probably can show where my hand is, where my right hand is. So this is the Evolut FX Plus. Beautiful color, green now. I like this color. So that's FX. we know it's FX wire. All right, so we just push. So you guys can see the side port. It's at 3 o'clock.
not
Hold
yet,
over.
but you should be at 3 o'clock position.
The camera
Yeah,
can
the
go to
flush
my
port.
right hand here. Yeah.
Yes.
All right. All right, you can see. All right, go ahead.
Now we can see, yeah.
Go a little bit lower. All right, you see how flexible is the FX here? Can navigate. Show the tip of the wire, please.
Yeah, it's actually quite
more.
calcified. The femoral
Yes.
ilium, yeah.
I guess that's one of the things that I want to highlight. This Evolut FX Plus, the tip is really taper, and I find out that if 14 friends go,
Yes.
then your valve will go. So what do you think about the head marker?
Is still in the AP or just the LAO? I think you have to
This is
go
still
to
in the AP.
This is
Yes,
the-
this
still in
is
the
the
AP.
LAO, so you can see the hash marker is in the outer curve.
Yeah.
Right. Can we go LAO 20? LAO 20, please. This is right. I want left.
This is
LAO.
LAO.
L. That's fine, because that's real. Okay, so this is also an important step. You open up the arch, and I think, it was highlighted during the discussion. This patient has a calcification on the outer part, on the ascending aorta. So we have to visualize when we move here, and, let's see together how flexible is the system. Okay, you can push. Chenji, I'm just holding the wire. Okay, I'm just pulling the wire a little bit. Very nice. All right. And I think the head marker is still in the outer curve. Pulling
Yes.
the wire here. Very nice.
travels all the way on the outer curve.
Yeah. All right. Keep pushing. I like this. Keep pushing. Yeah, it is in the outer curve. All right, right there. Okay, good. All right, stop there. So let's just pause here a little bit. This is LAO. Can you just make one a little bit to see the head marker? I hope everyone can see the head marker is in the outer curve.
Yes.
And then I think you probably just a little bit deep. You pull up a little bit. Okay, stop there. Okay, why don't we just do an injection here? See me? Don't change the angle. All right, so the picture is not in the
Pigtail is in the right cups. Yeah.
Yeah, let me just change it a little bit. So compared to the old system for the FX, it's important that you start a little bit lower. So usually we start in the base of the pigtail.
Yes.
Unlike the old FX, if you guys used to the FX system, you start in the mid of the pigtail. Because this Evolut FX doesn't dive that much. So if you start higher, most of the time you're gonna end up need to recapture. So let me just try. It's a bit far from me here. So we're still in the LAO. Let's just, if it's not, then it's okay to put on the right cast as well, I think. I think that's okay. You just push a little bit, the system. All right, stop there. All right, inject. Sini, inject. Inject. You're a bit too deep, guys. Yeah? You think it's too deep? I think too deep.
Is it still the right?
Right there. It's still in the right. We try. So do you always try to? We'll try. We can try one more time. Let me see. Still in the right.
So you can use a guide wire to help.
Try. I usually just turn the other way and then So it will go to the non.
Ivan, this is a cast overlay projection, right?
This is still LAO, yeah. So this is
LAO.
almost like coplanar. Yeah.
Coplanar view.
Yep.
Can we go to REO 20, please?
You can observe this in the LAO. You can see the dot have a tree, one, 2, 3. But when you go to the REO, it will be the 2, 1.
Yeah.
I think that's the one.
Like the crossover.
That's right. Yeah.
Yeah, so that's a very good point. Thank you. So let's just go to cast overlap now. RAO 27. Let's push a little bit the base of the picture.
The dot is going to in the left side and one in the right side, and the hash marker is central front now. This is the typical case for from the beginning of the Evolut to check the commissural alignment.
Yes.
Yeah, I think that's a good point. The dot is really helping here. So 2 on the left
Yeah.
side of the screen and 1 on the right side of the screen. So let's just open up here a little bit. So I probably will do it under pacing, but not yet. Okay, let me open. You just adjust. Yeah?
Okay.
Okay, start opening. Someone can show my hand here. Okay. Just let it dive a little bit. Push a little bit. Push a little bit.
So the cell expandable is different from the balloon expandable because all the tension is inside the capsule. And
140 pacing on.
And the capsule and
Push a little
all
bit.
the things that grab is different. So when design the capsule strength and the radial strength of the valve
Inject.
is interfere the jumping in and driving in. So FX is changed from the catheter. The valve, I'm not sure from the engineering part, but I think it's stable.
Okay, the
More
blood
than
pressure will
Evolut
drop a little
R.
bit. So I will open until the rumble position.
Yeah.
Right there. Okay, how's the blood pressure now? Okay, it will go up. Oh, see. Off pacing. She doesn't like pacing. Huh?
Mm.
Every time we pace, the blood pressure drop. Okay, we'll
Now
go
you
back.
come up,
Okay,
yeah.
it's back. Let's see the floater. So this is definitely commissural line. What do you think, Michael? 2, 1, 2 dot on the left, 1 dot on the right.
Yep.
Yes.
Yeah.
All right.
Very nice.
Yeah.
Let's just adjust the parallax a little bit. Give me caudal, more caudal. Add 5
Might
or
need
10.
to pace the patient a bit. I think Brady.
Put the backup pacing at 60, please. Stop there. Ini. Inject. What do you guys think?
This is too deep.
It's about +4 at the NCC, right?
All right, we can just try to recapture here.
Might be a
At the
bit low.
patient.
Yeah.
Yeah.
Maybe get higher.
All right, just leave it. Okay, we're gonna recapture. You probably pull out a bit. Sometimes you don't need some recapture. Pacing. Do it fast. 120 pacing on. Yeah, I'm gonna recapture. Right. Not yet. Okay. Sometimes you just by doing that, you reposition the valve a little bit. And one of the other thing is, of course, pushing the wire. Push a bit. Okay, I recapture all the way. I recapture
Okay.
all the way.
Yeah.
Sorry, recapture all the way. Stop pacing. All right.
Okay.
So the other thing is I will push the wire a little bit on the outer curve. All right. All right. Let the patient rest for a while. You probably need to support a little bit. We need to recapture. Let's check your position. I think it's still all right. Yeah, that's good. So what angle is this? Alright, 27 called it 35. Okay, can. You have to adjust. Let it for a while.
Is this still the cups overlap view?
This is a cast overlap, correct?
Yeah. Okay. Think you can start here.
Okay, all right. Okay, I open. Pacing 120. It's okay, just leave it. You're too deep just now.
Okay.
Okay, push. Okay, enough.
This is going to be good.
Inject.
Yeah, it's better.
Yeah. Just
Keep pacing. Okay, I open until rumble. Stop there. Off pacing. All right, good. We top up contrast after this. All right, we just leave it. How's the blood pressure? Good. The blood pressure is up. Sini, you ready for inject? Sini, inject.
Things
Yeah,
better.
much better. Yeah.
Yeah.
Yeah. So I think let's just go to REO20 angulation, co-planar. I think the left is a bit too deep, but I'll do a forward pressure here just on the outer curve.
Just like what Gilbert has said.
Yeah. You hold this one.
I think the position is good. You got commissural alignment.
Yeah, commissural alignment,
Yeah.
yes. Let me
Cups
see.
overlap
Just one
view,
more
two
time.
dots on the left side of
Like
you.
one. You ready, Sini? Okay, let's see here. Yeah, I think I like
Very
that.
nice.
Yeah.
Yeah, I think that's the best you can get.
You can put the caudal 25 real quick if you want.
For the
Bit more,
non-cast,
bit more.
it's just 2 or 3 millimeters, but for the left cast,
Yeah,
it's
just be
5.
careful. I agree.
And we can collect it with the layover for the final release.
So then you just look the wire as your thing, push forward. Let me see. Play one more time. Make sure the left coronary and the right is lighted. Play. But the left side is good. Left side, okay, good. Let me pull the picture a little bit. Toro. Okay, you guys okay? We deploy
Yeah.
here. What do you guys
Yep.
think?
Yes.
All right, pacing 140. Push forward a little bit. If anything, you can go deeper. 140 pacing on. 140 pacing on. Okay. You're gonna do it very slow, and you see what I do: 1/4 turn, and I stop.
Hmm.
One tap to just come up. Not both at the same time. Show a little bit higher, please. Slowly. Push
We will
forward.
always try to go slow in this step
Yeah.
because there's no rush.
Yeah, very slow.
Now,
Yeah.
yeah.
The pressure is still a
1/4
bit high.
turn.
You may want to push
Yes,
pace a bit
you
high.
see the blood pressure comes up.
It's the 27% oversight. So this period is easily squeeze the frame and make the wall pop up and pop down. So this step will be very, very slow when
It's
you
slow.
do the final release of this wall.
Okay.
Not what I
One-
want.
One more
but then
tap.
Both at the
One
same
tap
time.
is not yet released. Yeah.
Yep, both
Okay.
release. Okay, this is an important step. Off fluoro, store the image.
Yeah. Nose
At this
cone.
point,
Be careful
the
of the
nose cone. So
cone.
I pull the
Yeah.
wire here
Yes.
to make the nose cone go. Stop pacing. Yep. I think that's it. Okay, change it. Pull. Okay, and at the same time you push.
Okay, push wire. Well, very nice.
All right, let's recapture. Okay, you push the wire. I will capture here. Push the wire. Sorry. Enough. Okay, all right. So let's do a picture here. I think it's just a parallax. Just do a final picture here just to make sure. Feel like a bit too high. Where's your picture? You see the picture? I didn't see your picture. Wait. I think you too deep, is it? Be careful. I think you inside the crown. Okay, why don't we just put a wire just for safety? Then we top up the contrast at the same time. All right. Meanwhile, can we show go live on the echo? I'll show you guys.
Okay.
So
Here
I
are the
think Michael,
transthoracic
I'm not. Yes, we're transthoracic. I'm not comfortable with the picture. Did you see that? I mean, probably it will be okay, but I just do not want to take any chance. So I just put a wire here, just to free the picture.
Okay.
I think it's just trapped somewhere in the crown. We can show you the echo. Yeah, I think it's trapped. Sometimes all this small stuff. There you go. All right. Well, that's
free.
much better.
Yeah.
Yeah. All right. Well. Yeah, I think it should be all right there. It's okay. Just use more. Okay. You wanna go live on the echo? Why don't we just put the centron back? Okay. Hold this in.
Can we see the echo? We can't see the echo.
Yeah. We can see that you hold this one. You got the picture. I'll do the echo real quick. Wow, we all. Where's the gel? You set up with that one? Okay, let me show you guys the echo here. You haven't take picture, guys. Okay, that's the echo. Can you guys see?
Yes, we can see the echo.
Okay, put color. Click there.
Yeah.
Yeah, not much regurg that we can see.
Let's go to apical file. Sorry guys, echo is not the best. This is Ivan version of echo.
That's good enough.
There's not much
Oh,
leak
very
there.
nice.
No leak.
No
Can
leak.
we check the gradient in the echo? LV function is great. The blood pressure is good. Right there. Okay, pause. Okay, let me just work on that and then just I'm gonna give you guys the
Hemodynamics.
yeah, the hemodynamic. Okay,
yeah.
push forward and straight back. Okay, let's just center ready. All right.
Yeah. With pressure gradient just only 4. So it's
So the mean gradient is 4. Yeah, it looks good. There's no leak.
Very
Okay, let's
nice,
just show the
yes.
hemodynamic. Okay, floor. All right, wire. AP unmake, please. Kenji, wire.
So usually when we deploy the expandable valve, we have to check in the LAO and the IO view. IO is the
Yes, I
minor
was just about
axis
to say.
to check the
Can
expansion
we go to
of the
RDO
valve.
27?
You can see in this
Corridor
view,
35.
both IO and LAO, they are the same diameter. So that means the valve is fully expansion. This is the one of the guarantee that you will have the good functional of the leaflet and have a longevity,
Yes.
get better longevity.
Mag 1. So I'm going to show you the cast overlap. Probably, Michael, you can explain. Oh, there you go. That's the cast overlap view, guys.
Yep.
Yeah.
So you see the
So
big
I
hole.
think,
Can you see the big window for the coronary?
Yeah. Can you play again? I think there's a very nice image just now. Yeah, and I think we achieved commissure alignment.
Yeah.
Yes, I think you achieved.
That's what we promised. Yeah.
So
Alright.
it's going to be a very easy coronary reaccess in the future if she needs coronary intervention.
Yes.
So
All right. So we'll
good
show you
for
the
her.
gradient. Sorry, push this way. Yeah. All right. We'll show you the hemodynamic now.
Yeah.
Why don't we just show? Do you guys have the pre-hemodynamic? Put it on the screen one more time so everyone remember. Yeah, that's the one.
Yeah.
So we'll show you the post soon, and we'll take a picture after this. Final injection 20/10, guys. All right.
Okay.
All right. So this is the final gradient that we have.
You have to flush the contrast away.
Yeah. Where's the other? Oh, sorry.
Very nice.
The other one? Oh, there you go.
Mm-hmm.
Can you paste? What's the pacing now? Probably a bit of PVC here. There's a little bit of PVC here. It's a bit
Yeah.
hard to see. Let me see. We'll move the wire a bit. Okay, there you go.
Can we see the hemodynamics? We cannot see now.
Can you guys show the hemodynamic?
Yes.
Let me zero the line here. As Michael say, you have to get rid of all the contrast here. All right, there you go.
Very nice. Single digit gradient. That's all.
Yeah, beautiful.
Basically, not much gradient actually.
Yeah.
And then you
Yeah,
see
I
a
think there's
very
a
nice
good dichrotic notch as well.
dichrotic notch and a very satisfactory diastolic blood
If
pressure.
you want pacing at 80. Let me just pacing at 80 just to show you guys, there's so much PVCC. There you go. That's a much better. How's the
Very
blood
nice.
pressure? Blood pressure is all right.
Excellent results.
Yeah. So maybe Ivan, maybe just a final
Angel.
angiogram, and then we'll let you
Sure.
go.
All right.
Very nice result.
Will do.
Nice
Let
result.
me see. Let me just take out the wire here. And then just final injection 20 for 10, G wire. Oh, what angulation you guys want?
I think as long as you solve
Alright.
all the parallax,
Yeah.
any angle will be fine. Either coplanar or the cups overlap will be fine.
Give me more corridor, please.
This will be good, yeah.
A bit more corridor. Let's see a bit parallel. Oh, the other way. Take out the corridor.
The markers do help us to take away some of the parallax. Yeah.
Exactly. Yeah, that's very easy, isn't it? All right, there you go. Okay, let's do a final injection. 25 for 10. Ready? Jack?
Yep.
There you go, guys.
Very nice result. We don't see any regurg and minimal gradient.
Still have chori perfusion. So that's
Yep, the left and the right. Yep.
And then you preserved coronary reaxis doing commissural alignment with this Evolut FX Plus system. So thank you, Ivan. Very nice result. Congratulations.
Thank you, guys.
So we will see you around in the conference center. Okay.
All right, we'll see you around, Michael. Thanks, everyone.
Very good result. Okay. Now, you want to do some image
this
analysis?
case in the borderline zone because the acceptable valve is 20 and it's also the 20 in the 23 and 26. Today we choose the 26 for the 27% oversizing and this is a 13%. So we already know that his nominal septum is just 5. So we choose the hemodynamic and we see the pacemaker. That's why we see the heart block in this case. But sometimes maybe we have to choose this one to avoid the heart block. But the EOA here is just 20 millimeters, so it's enough for this patient. But sometimes we have to pro and con in every situation in the TAVI procedure.
Yes. And if we want to achieve better hemodynamic result, we intend to use a bigger valve, as mentioned. Dr. Wu, can I ask which Medtronic device are you using now? The Evolut FX Plus or the Evolut R?
So in our country, recently we have the FX.
Oh,
We still not have the FX Plus. Maybe next year, at the end of this year or next year, we have.
so you have the 3 dots already.
Yeah.
So in comparison to the Evolut R, how useful do you think are the 3 dots?
Yeah, I think it has a lot of things we feel that the first one, the delivery system more stable, and also the second thing is that when we deploy the valves, it's more stable than previously. Previously, we have to control everything, but this FX new version we don't have to control too much. Just keep it stable, more gentle to do the case, and technique also different. And also the last thing is about the coronary access. After we implant the valve, we have more space to do the coronary access of the patient. So everything seem more simple than before and more easier than before. Yeah.
And Gimbui, can I ask you, well, we see how good the commissural alignment has been achieved in this case. But just in case you do everything, and then there's really no commission alignment. What would you do? Do you aim at realign, or you just go ahead and deploy?
As much as possible, we try to realign, but that means you have to take the whole thing out and descending aorta, rotate and come back again. For instance, we try to do our best, but as we mentioned, if you follow the steps, 90% of the time your head markers are outside, you're going to get commercial alignment. And now with the with FX Plus, if you have that, that is also another less of a worry in terms of coronary access in the future.
Yeah. Yeah, please go ahead.
So Evolut is crazy about the coronary alignment. You can check from just the beginning. During you are in the aerial view, you can see the hash marker in the outer curve. And when you see the cast overlap, you have the hash marker central front, 2 dots here and 1 dot here. And after you use the 3 cast view, you can see the dot in the 3 views. And also the hash marker will be at the website. All the things that we try to show that we have a lot of things to make everything have the easy to do coronary access.
Yeah. The dot is the post. So when you the cups overlap view, because the left and right cups are just overlap, so they are both on the left side. So 1 dot means the highest point is actually in between the left and right coronary artery. Yes. Yeah. So that's called a perfect commissural alignment. So we can align the commissure so that for future coronary access, it will be much easier. And Anurag, you also mentioned about this radio strain, the delivery system. So how do you like the delivery system? I think it's much more stable.
Because in Thailand, I use a lot of self-expandable, many models. Sometimes the capsule is very strong, like the vital flow, really weak, like the Hydra. We cannot recapture it much, but Medtronic is in the middle. We can play and we can learn the standard things from the Medtronic. And if you want to use the cheaper valve, maybe you can try the different things. The capsule of the vital flow is very strong. You cannot compress it by hand. Maybe by foot is okay.
So this will make the procedure much easier, I would say, with the easier delivery system, more stable. You can actually cross easier and then have a more stable delivery. So I think we have had a very, very nice case and very nicely done. The case was completed very professionally, I would say. So if I can conclude today's session, we've seen a patient, a very elderly patient, 86 years old lady with very small annulus and with concomitant coronary artery disease. So what the team has been doing is try to achieve good hemodynamics. I think by using this self-expanding Medtronic Evolut FX Plus system, is a super annular design with a bigger size valve, 26. You can achieve actually much better hemodynamics even in this small annula. So the dot markers has been very helpful in ensuring there is a commissural alignment, because in this particular case, commissural alignment is very important for future coronary access, just in case the patient got coronary artery disease in the future. And you also see the FX Plus with the big window. When you do commissural alignment, you will actually open up a big window facing the coronary artery. Actually, it will be easier to engage the coronary artery. And then last but not least, we've seen the performance of this FX Plus delivery system. Very, very slippery, very easy to deliver, and very stable to ensure coaxial deployment and finally perfect commissural alignment. Well, thank you. Thank you all for coming to this session. Thank you, my spokesperson and panelists, procedure analysts. I hope you've enjoyed the case. The case has been very nicely performed. Thank you for coming, and please stay for the next session.